Good day. Welcome to this panel, and good day to wherever you are in the world. I'm Howard Francis from Duke University, and this is the panel, How the Past Shapes the Future and What to Do About It. And I am indeed privileged to introduce this distinguished panel, starting with Dr. Teresa Caraway, who's a speech and language pathologist with extensive experience in the rehabilitation of deaf and hard of hearing children, and is now CEO of Hearing First. Dr. Cliff Majarian, a neurotologist and a cochlear implant surgeon who now is full-time involved in health system leadership as the CEO of University Hospitals Health System in Cleveland, Ohio. Dr. Deb Tusi, also a neurotologist and CI surgeon, now the director of and of course that is a full-time job, of the National Institute on Deafness and Other Communication Disorders. Mr. Peter Thomas, who's the principal partner of the Powers Law Firm, and has a federal law and legislative practice in the areas of healthcare and disability policy, Medicare coverage and reimbursement policy, and also medical rehabilitation services. And Dr. Jason Wigand, a cochlear implant audiologist who himself has hearing loss and is a user of cochlear implants. So, the cochlear implant, just to set the framework. Cochlear implant, it's a marvelous engineering development, and it's a marvel of medicine that has also transformed the fields of audiology, speech and language pathology, and special education to bring into being a new age of opportunity for millions with disabling sensory hearing loss. While we celebrate these accomplishments and our ability to advance, it's really important that we advance the field and address large remaining concerns and needs that really impact this field. The current state of cochlear implant practice in the United States is defined by the box here that demonstrates the limits within which we currently practice. And this has served us well in the first 30 years of cochlear implant practice in the United States. The walls of this box, though, are changing, and they're changing beyond our control. And these changes are reshaping and potentially deforming the way we practice, which demands that we pay attention to these trends and not remain imprisoned by outdated attitudes and paradigms. To advance this great legacy that we have inherited, we must be bold and proactive in response to current change and even anticipatory for what is likely to follow. So this panel was pulled together to try and address this in an hour. Can you imagine? Not a lot of time. Just to give you a sense of the framework, how we're going to approach this. We've had conversations leading up to this panel. And what we've done is, in the context of the threats and opportunities, we'll try to address the 4 levers available to us to reshape the future of cochlear implantation: technological development, cochlear implant service delivery models, professionalism and standards of care, and policy. And we'll divide our discussions into 3 themes as listed here: patient perceived benefit and experience, sustainability and new reimbursement schemes, and finally, access and relationship to provider attitude and practice. You can certainly enter your questions in the chat, and we will certainly try our best to get to them as the discussion progresses. As we prepare for the first theme, we have an audience question. Which of the following is most likely to enhance patient benefit and experience? Is it facilitating early access, increasing patient advocacy, or lowering device price? And the best of these 3 answers is to facilitate early access. So my first question is posed to Dr. Tusi and Jason Wigand. Our purpose begins and ends with the patient. What do you consider to be the top 2 or 3 issues that stand in the way of advancing the patient experience with cochlear implants, and what do we need to do differently to address them? Maybe Deb, you can go first.
Great. Thank you, Howard. Good morning, everyone, and thank you for the opportunity to participate in this wonderful panel. So in thinking about this, I think that there are 2 main levers that we can think about to improve patient perceived benefit and experience. One is service delivery, which really determines access to cochlear implantation, and I'll talk more about that in a minute. And the second is technology. So how can we ensure the best possible performance for patients and lower cost of care or cost of access to care? And in thinking about cochlear implantation, I think over the past 20 years, the advances in technology have really been incremental and not transformative. So what I think we need to do as a community is to think, what can we do to really transform performance of both cochlear implantation at the patient level and access to care by providing technologies that can be leveraged by the medical community to improve the surgical procedure and postoperative rehabilitation. So on Thursday, I heard a wonderful lecture by Tina Stankovic that talked about some of the technological advances that are on the horizon. And I think that she laid out in very elegant fashion some of the things that we might think about going forward in terms of electrode and implant design. And then following that was a fascinating talk by Bruce Gantz talking about the use of robots to insert cochlear implant devices. And I think that we can think about that even more broadly. How can we use robotic techniques to supplement surgical practice and knowledge in areas that perhaps are underserved in the United States or overseas in low and middle income countries? How can we use technology to supplement surgical know-how to make sure that implants are inserted in the best way possible? We also heard about imaging. So I think all of these technologies will converge and bring us forward in ways that really can democratize cochlear implantation as a field and make it more accessible. There have been very few advances in terms of manufacturing of cochlear implants. So, for example, thin film technology has been used in brain implants, and this is electrode technology that can be mass produced, machine made, so it doesn't depend on the painstaking creation of implant by hand in the facilities that we know today. Mass production can also decrease cost and also gives us some opportunities to improve performance. So I think those are some of the things to think about in terms of technology, but perhaps the most low-hanging fruit is in service delivery. So in this country, we have a highly successful model of newborn hearing screening, and it provides early indication of hearing loss in newborns in over 95% of births in the US. But the conversion then to diagnosis and treatment is much poorer than that. And how can we do better? So we know that there are many factors that contribute to poor access to care, including racial disparities, insurance disparities, geographic access in rural communities and inner city communities, care networks that are accessed through family care physicians who may not have very much knowledge about cochlear implantation as an option, and then parent-related issues such as non-English speaking parents and single parents and those really without the access to services that they need. So there are a couple of programs that come to mind as potential best practices in this regard. One is present in North Carolina called Beginnings, and this is a program that's connected very closely with the newborn hearing screening reporting structure throughout the state. Joni Alberg and Matt Croson and I reported on that a few years ago, looking at transition to care, and it was highly successful in bringing children from the newborn hearing screening program to care delivery. Another program is funded by the NIDCD. The PI is Matt Bush, and he's looking at the use of patient navigators in rural Appalachia and Kentucky to see how they can improve transition from newborn hearing screening identification to care. So I think all of these programs involve new ways of thinking about service delivery that can be used both in the US and overseas in low and middle income countries, task sharing and other advances that can help us to develop a network. I think a wake-up call was published recently by Liu et al. This was looking at access to cochlear implantation in the state of Florida, and identified that Black children, Hispanic children, and children with Medicaid coverage were significantly less likely to be implanted before 2 years of age. And this has been shown by other investigators as well. This is not better in high implant program settings. So this is a reflection of systemic inequities in care that I believe we really need to address. And I'll end there.
Thank you, Deb, for raising those important points that we will hopefully expound on here in a moment. Jason, I'd like you to present your statement, please.
Well, thank you, sir. Thank you, Dr. Francis, and thank everyone for including me and some different perspectives in this panel. I believe, as Dr. Tucci said, service delivery is one. We operate under a one-size-fits-all approach to, and this is after an individual is a patient. So there's plenty of opportunity in hearing healthcare and identification and so forth of cochlear implants as an intervention in general prior to being an individual being identified. But a one-size-fits-all approach to oral rehabilitation, identification, explanations of outcomes and performance. Cochlear implants require extensive rehabilitation. I don't think we focus enough on that initially and throughout the process. And again, we expect outcomes to be a certain way, and when they're not, we don't have a reason to explain it. We have no reason why. So an adult patient's routinely sent home after activation without any real structured rehabilitation program. In a lot of cases, we don't have an established best practice or standard of care in this regard. The lack of evidence-based auditory training methodologies combined with the absence of insurance reimbursement for clinical audiologists to manage intervention protocols is partially to blame. I mean, over the past 30 years, improvements in performance, outcomes, speech perception, as measured in the sound booth with open and closed set stimuli under various manipulated conditions. It is honestly mostly due to improvements in sound processing and encoding strategies. So, studies show that patients may continue to improve their performance for up to 3 years following implantation. However, it may be possible to enhance that process of adapting to the implant with individualized focused training and using what we understand, the neuroplasticity of the brain, and incorporating those sorts of that sort of knowledge and utilizing that kind of intervention, at least kept in mind when we are looking at improving the outcomes. One problem with current auditory training studies has been that their focus on developing training protocols are related to word list and sentence test scoring in the sound booth, right, with the possible manipulation of the signal. And then the patient's subjective personal difficulties in noisy environments. How do you hear there? How do you hear here? Rather than an understanding or really incorporating the causal factors that may be underlying the deficits, right, that lead to observed performance decrement. Also, secondly, is the availability of providers and clinics, right? We have probably a dozen major centers throughout the country. But as Dr. Tucci mentioned with Dr. Bush and his studies, his area of research he's pursuing in Appalachia, the access to care is an issue. There's a need to increase the number of clinics and providers. Too many are challenged by the lack of availability, time lost from work, personal duties, whether due to distance, lack of appointment times that are appropriate to that individual's schedule, number of appointments, length of time. There may be 4 to 5 medical appointments prior to implantation, okay? And then a minimum, I think the average was 8 point something, but 6 to 8 to follow-up appointments with audiology within the first year. So some things to propose. I mean, we continue to fund research but in ways to incorporate quality of life issues, right? Incorporate subjective measures of outcome. Little research has been devoted to the efficacy in terms of improvement in quality of life in CI patients, and understanding and explaining reasons behind the enormous variability in outcome and benefits. We can explain word understanding and speech perception and noise and have those numbers, but we still have a long way to go to explain some of, again, those underlying causal factors and deficits that may exist prior to implantation that we take into account with regards to assessing performance and outcomes after implantation. Next, I believe that an established best practices in cochlear implantation, especially with audiology and otolaryngology, and a standard of care. Audiology does not have a standard of universally accepted standard of care, and our patients have that experience. They recognize that they get different experiences going to different places just at the beginning of their journey in trying to get some treatment and identify the hearing loss. Every patient could be screened, some kind of screening measure for cochlear implant candidacy. Where you have established measures, say a 4-frequency pure tone of 55 or 60 dB or higher, and word recognition scores less than 60%, either, something established where they are being introduced to the cochlear implant interventions. Making sure otolaryngologists and audiologists know where to refer patients for CI evaluation. Publish and maintain an open access database for patients. And then finally, creating some content and ownership on candidacy, advocacy policies, or rehab, just increasing that awareness, which we'll speak to a little bit later as far as how we can improve that. Definitely the service delivery structure and the standards of care that are lacking in the patient's journey, and especially continuing when they are looking to evaluate their own personal outcomes, their own personal expectations, if you will, and
so,
how it's
Jason,
viewed.
You raise really critical points that I want to bring in Peter Thomas to comment on. Both you and Deb, I mean, I hear concerns about the variability in outcomes, but also variability in practice, this variability raises the question of really how we optimize our quality, right? And there are some phenomenal examples of excellence, but the scaling up of that and really characterizing it so that we develop standards, you both raised those as issues. And I would like, from a policy framework, through a policy framework or lens, Peter, if you could give a comment, brief comment, or your thoughts on those issues.
Sure. Well, clinical practice guidelines are not something that the government has taken to trying to have a lead role. They'd like to defer to the science. They'd like to defer to the providers to really kind of develop clinical practice guidelines. But part of this goes to the issue of awareness of CI, not only within the provider community, when to make the referral, when that more standardized kind of test that Jason was just talking about is appropriate for a particular patient, for a particular individual with hearing loss, but also within the general public, just knowing about the availability of CI as an alternative to either hearing aids for people with profound or severe hearing loss, or for their child to as an alternative to many other forms of hearing help. And so I think the awareness level is something that the field, in a sense, suffers from, and it's an important barrier that needs to be overcome to the maximum extent possible. Not easy to get at that, not easy to correct that, but you can achieve some of that through policy, through working with Congress and the federal agencies, with payers, and of course with the provider community to make sure that they have as much awareness of CI and when individuals are appropriate for CI as possible. I have some other things I want to talk about in terms of prioritizing policy, but let me defer to Teresa at this point.
Yeah, so I don't see the questions, the chat function right now, but I do have a question for both of you around how, in fact, probably a little bit more for Deb, around funding mechanisms to advance the scaling up of best practice. We have sometimes a challenge translating what we're discovering in the laboratory in a control situation, in a sort of best practice situation to the real world, and we don't necessarily always account for differences in experiences, thus the disparities that arise from that. So I'm curious what your thoughts are on sort of a framework that would allow us to do a better job of that.
Well, that's a great question, Howard. There are many demonstration projects across the country of investigating the best way to integrate those who are currently underserved into the hearing healthcare system. And so I think that our challenge is to take it from that demonstration project stage into a more broadly applied model. And some of it has to do with funding, but some of it also has to do with the demonstration project showing the cost benefit of these types of interventions. For example, the patient navigator in Matt Bush's study. So I would envision, if that is a successful model, which I think it will be, in having a very large demonstration, multi-site project that demonstrates that we can do this on a much broader scale. And I think that we can do that within the NIH framework. And then you provide excellent evidence of cost benefit that can be directed towards insurers and others who are interested in policy and payment models.
Really interested in the next theme, because I'd like to have us superimpose what we just discussed over the realities of our payment methodologies. And as we sort of project into the future, how we can get them to converge and really meet what we see to be the priorities. But so let's move into the audience question number 2. Which of the following will help to preserve cochlear implant access in a value-based, that is sort of shared risk reimbursement model? Is it faster speech processing? Is it faster and easier mapping? Or is it increased choice through redundancy? And I think that the best of the answers here is fast and easier mapping. And so let us actually get into that discussion. And for this theme, we've asked Cliff and Teresa to, I was going to say spar, but this is not a sparring exercise. This is more us sharing your thoughts about this based on the comment here, which is cochlear implant services are not delivered in a vacuum. Patient access to these services is heavily dependent on their sustainability within the healthcare system and the models of care and professionalism standards that guide practice. What are, in your opinion, the 2 or 3 top threats and or opportunities that warrant our attention and action in the near term? Go ahead and ask Cliff to start. You're on mute. There you go. Yeah.
Yeah, I think, am I okay now?
Yes, you're good.
Great. This is a very fundamental question that is being asked. I'm speaking now as someone who's taking my cochlear implants hat off and looking at someone who's observing how hospital systems, which is the fundamental first stop for the delivery of cochlear implants, are being, if you will, viewed on services that are viewed to be expensive. I mean, make no mistake, the cost of a cochlear implant, the device itself, puts it, if you look at DRGs, a very expensive procedure, similar to a TAVR or similar to a very expensive piece of spinal hardware. So on a global scale today, I think patients have access to cochlear implant services at literally hundreds of towns and centers across the United States. I think we have to be aware of the fact that healthcare consolidation is a real issue. It's I'm not saying it's good or bad right now, but it is happening. We used to have 5,000 hospitals just a few short years ago. They are consolidating with the absorption of smaller hospitals into larger ones, and then larger ones into mega hospital systems. Our system, University Hospitals, just a few short years ago, was essentially one large hospital. Now we're 22 hospitals. And what is going to happen is when systems are consolidated, if you will, to large, and even more so in the for-profit hospital world, that will force the system to consider rationalization of service delivery, specifically an expensive process like cochlear implantation. And I think cochlear implant has been off the radar because it's fairly small in terms of numbers, but it's coming. And so what's going to happen is larger systems will rationalize cochlear implant surgery programs, if you will, to select parts of that healthcare system, because what the systems are looking for is economies of scale in response to challenges in terms of pricing by both commercial and government payers. It will therefore behoove, I think, cochlear implant programs to work toward perfecting not only the ideal quality of service delivery as perceived by the patient, but also in measuring, if you will, the overall cost of care of that bundle of service. And I think there's 2 bundles in the cochlear implant world. There's the surgery itself and that visit, if you will, and then there's the programming and rehabilitation part. So I really believe that the notion of perfecting not only the quality, but also measuring the cost of care and the unit cost of care for the entire bundles of those 2 parts are going to be necessary for programs, if you will, to withstand, if you will, the scrutiny that is coming. And make no mistake, this is happening now today. The government has at least 62 bundles that I have to prove, at least on a voluntary basis right now, but soon to be mandatory. Those include knee replacement, hip replacement, TAVR replacement. Soon cochlear implants will be there. So programs and centers that cannot demonstrate quality and efficiency at the lowest cost, free of, if you will, complications and things that drive up costs, like the need to switch to a second device, the need to have a long surgery, which leads to hospitalization, and the issue of complications and things like that. Those programs will be vulnerable to being really shut down by consolidated entities and moved to parts of the system that can demonstrate that. One more quick statement I think we have to think about is that it is possible, as I mentioned before, that the policies that are implemented now by CMS and many of the other players, Anthem, United, in terms of centers of excellence, will become not voluntary, but will become actually mandatory. And the measurement of the total cost of care will be something that will enter the cochlear implant realm. So what is happening with CMS and payers adopting that framework where the entire clinical costs, including post-op care, et cetera, will be public, will be known, just like we, if you will, have public reporting of outcomes after cardiac surgery. So this will force, and is already in some specialties, it will force cochlear implant programs in hospitals to pick the most efficient surgical teams that produce a surgical product free of variability That's the concept, right? Free of variability, that as it relates to the outcomes of cochlear implant and that sort of thing. Like, similarly, I think, as mentioned by Jason, the concept of not necessarily the government saying that the total cost of rehab, mapping, and programming will be, that cost will be, if you will, challenged, and those who can adapt to creating the most streamlined process that is most effective will be rewarded. So I'm saying this because I do think in ENT, many of our, if you will, services have not yet risen to the level of being viewed by the payers, but they are soon to be. So it's really a challenge. Those are the threats. We just have to respond to it.
Thank you, Cliff, for those comments. Teresa.
Well, thank you. I come to this panel with many more questions than I have answers. So that's, and I hope that just the conversation that we're having spurs additional thoughts or ongoing conversation. But, you know, it's building upon what my esteemed panelists have said, and that is we're going to have to think differently about what we do. And what I mean by that is I think we're going to have to think about it in terms of as an interruption of how we have always thought of providing cochlear implant services. And what I mean by that is, I think, Jason, you hit on it, that it's not one size fits all, that we have to have individual, but I think we have to leverage technology, leverage how we distribute. I'm talking particularly the rehabilitation part. It is also concerning that there was a statistic presented yesterday that less than half of the counties in the US have an audiology access to them. So we're going to have to think about how do we get services to where people are. And that may take some innovative thinking, innovative partnerships that we haven't even begun to look at. But I think the bottom line is that we need to take an end user perspective. We need to learn from the end user of the customer. In other words, the individuals who are candidates for implants, the parents, and learn from them what they need, what they want, and what would be responsive to their needs so that there are more access to implantation.
Thank you, Teresa, for those comments. And let me there are a couple questions, but I'm going to follow up with my own questions initially, starting with Cliff. You know, you've heard Jason and now Teresa, but also Deb talk about quality and variability of outcomes. And of course, the quality that you are talking about, does it really include that quality? Does it include the patient experience in terms of the speech perception outcomes and the engagement, social engagement outcomes that we all think about? And how do we elevate the value of that outcome to get the resources to support the services needed to achieve those outcomes? I'm sorry, it's a loaded question.
Yeah, well, you know, let me just be honest and frank. Let's just take, to answer that question, let's look at what the payers are doing in a space that's already moved into the value hunt. And let's look at knee and hip replacements right now. How do the payers and the government, and you know, for example, we have contracts with Walmart. They deliver their patients direct to employer because what they want is they want to know that their patient is getting a knee or hip, that at least 50% of it will be done on a day surgery basis. Those who are admitted will stay 1 day, and they'll be will essentially guarantee their 90-day bundle. And so that's step one. And so I think what will happen in cochlear implantation is that the total cost of the expensive part, but not the most expensive or most important, but the surgery part at the beginning will not have long-term outcomes as a measurement. They will have short-term outcomes. Over time, however, the next will come the long-term outcomes in terms of speech perception, patient perceived quality of the service. But at the beginning, the notion of eliminating variability from the hospital-based part of this will be the initial focus. Later will come the notion of data being public about patient perceives outcomes at a year and 2 years. So I think those would be separate issues. Then your question is, how do you fund it? Well, I think we have obviously many through the NIDCD options, like Dr. Bush, of examining delivery systems, but ultimately this will be self-funded. Why? Because the hospitals are desperately going to want to maintain at least doing some of these services, and they're going to have to find their own mechanisms, at least on the hospital part. I don't see there being gobs of money available for research into helping a hospital come up with the best, if you will, overall organizational scheme for cochlear implantation. That will have to be self-funded for hospitals who want to continue to play in that space.
So there is the implication for consolidation that I hear over the future, that there will be selection and narrowing of referral networks so that high quality patients go to high quality and better cost, and so that could mean access. Have implications for access, right? So, Teresa, you've talked about the use of leveraging networks and the needing to reinvent a way, rethink how we create these networks and who, perhaps partnerships, telehealth, et cetera. Can you comment on an example that you have actually considered or perhaps had experience with that we could start thinking about leveraging?
Yeah, what's interesting is that we've all experienced the crisis of COVID, and it's caused us to learn how to use Zoom. The favorite line is "you're muted," that we've all, and it started out being very polite at the beginning, and now we're just quite frank when we tell each other we're muted. But the bottom line is, what we're talking about is a very different world in terms of how we can connect, what types of remote technologies we can use. I think we also need to start thinking about, where do people hang out? Where are they? And if you think about Walgreens, if you think about CVS, if you think about Sam's, if you think about Costco, people hang out there. And so if there were ways, I've heard a lot of presentations about remote mapping, where they're, implant departments, they're shipping off a Surface or a computer or a laptop, iPad to a family, and then it ships back. Why can't we put a simple Surface device or some device in at Walgreens, and the patient goes there and hooks up for their remote mapping? So I think there's some partnerships, some innovations that we need to consider. I also think that what's happened is that we have this marvelous device, and Deb, you touched on it, that we're now at this point where we need to be thinking distribution of it. And how do we have the public understand and know that this device is available? And I think it's how we communicate that. But so I think that there's this opportunity that we have to really think quite differently about how we're providing those services. Now, granted, people are still going to have to visit the surgeon, but how do we take this highly specialized practice and make it available to wherever people are living and wherever they hang out?
One may ask, are the profit margins going to be narrowing to the extent that people choose not to pursue cochlear implants as a profession? I think that so I guess to what extent do we how do we go about lowering costs? Right now, is the device the largest cost, or are there other areas where we see the costs opportunities for reducing costs and hopefully preserving that margin that allows people to remain engaged? Cliff, thoughts? You're on mute. And I said that very directly.
Yeah, very directly. You're asking a good question. I can tell you in many programs that I've looked at, ultimately what drives the ability to have a cochlear program not be, if you will, perceived by the system as being a money-losing process, that is driven mainly by two things: volume of activity, in other words, allowing for the services to become, if you will, highly systematized, And number two, some of the reimbursement schemes and the payer mix. Most hospitals who have commercial contracts, if they're smart, they've developed carve-out programs. So you could immediately, if your hospital finance department and the contracting department hasn't done this, most commercial insurers are amenable to creating carve-outs for the cochlear implant, which will make your commercial book of business profitable, at least modestly. And then, as you know, in the Medicare frame, if you can break even if you have a very predictable surgical product. That means that your team of surgeons are doing surgery in a very reproducible manner, an hour and a half to 2 hours at the most. The patients are done in the morning. They're able to go home. There's no question of patients needing to be admitted, and you're not having a surgeon who's fiddling with a backup almost ever. They're able to do it promptly with the first device. That is the way of making, if you will, at least breaking even. Now in Medicaid, it's variable by state by state. Some states have at least very reasonable Medicaid. Some have horrible Medicaid reimbursement policy. So I think overall, the way to take a program that perhaps is perceived to be unprofitable on a chopping block is to make sure your surgical variability is minimal. And we did that with all of our hip and knee orthopedic surgeons, 64 of them. And the ones who weren't able to meet that of their top peers were trained further, or they're not doing hip and knees anymore in our system. Yeah. And then we made sure we had the right contracts, not only with hip and knees, but cochlear implants, carve outs the commercial book. And we drove volume to offset, if you will, the losses on the Medicaid frame. So it really takes two things: working with your contracting for your commercial book, and then increasing your volume so your payer mix is what's perceived to be desirable, and then eliminating variability in the surgical product. And there may be some folks who shouldn't be doing cochlear implants, and that's okay. But this really needs to be done by the top. The top leader of the cochlear implant program needs to educate themselves about the financials of their program.
Thank you. Peter, do you see any policy dimensions or opportunities here? You're on mute.
Forgive me. I do. There's a competition of health services today. The Medicare program, just to take it as an example, because it is a federal program, and the Congress has extensive authority over how that program is run. They currently don't cover hearing aids, as people know. There's efforts in Congress to do something along those lines. And part of what the ACI Alliance was doing last year was trying to make sure that if in fact they did provide coverage of hearing aids, just as one example, that they didn't in any way put their finger on the scale to encourage that as the dominant hearing health option, as opposed to CI, when in fact a CI referral would be appropriate. So we worked hard to try to make sure that was not, that awareness level and that referral was available to someone in that position. It turns out that they've changed that bill. It passed the House, didn't pass the Senate. They've now changed that bill, the construct of the bill, and it largely has been resolved. Part of the problem, part of the reason that they restricted hearing aid coverage to people with profound and severe hearing loss in that bill, H.R. 3, which is the prescription drug reduction bill, trying to reduce the price of prescription drugs, but they get huge federal savings as a result of that, and they wanted to expand the Medicare benefit with hearing, dental, and vision benefits. And part of the reason that they confined hearing aid coverage to profound and severe hearing loss is because of cost. This has to go through the Congressional Budget Office. And, when you look at the numbers of people who could benefit from hearing aids across the country, they had to figure out a way to rein in the costs so that the trust fund, the Medicare trust funds, were not overburdened. They're overburdened now. We're seeing that the Medicare program is scheduled to become insolvent in a few years, and there's going to be tremendous pressure after this gigantic glut of spending over the past year, there's going to be tremendous pressure to rein in healthcare costs in a significant way. And we should all be prepared that that's going to happen, not only in Medicare, perhaps in Medicaid as well. So big implications to reimbursement, for reimbursement of CI and many, many other health services.
So we do need to create space in our schedules to really be advocates beyond our daily work to make sure that bad policy doesn't come through and that we promote good policy. Thank you, Paul. And let's go to the next audience, the final audience question. There's some great comments in the chat that deserve time, but they're at least available for you to read. This question, which of the following is most likely to reduce disparities in cochlear implant access and outcomes? Partnerships with local health and welfare networks, grant funding for public-private partnerships, technology development to facilitate remote care. I could make an argument that all three are the right answer, but I'm going to go ahead and take license and say that the third is perhaps at this moment the answer. And I would like to move into our final part of the discussion, really primarily Jason and Teresa. So what are the 2 to 3 attitudes or practices that stand in the way of expanded access to acceptance of cochlear implants? What should be our first steps to change these impediments to progress? And this time, Teresa, do you want to go first?
Sure. I was hoping you'd say Jason go first. No, I think that I hate to say this, but I wonder if we stand in the way. We have made it too complicated, or the way we're thinking about the delivery of services. And I think that if we look at how cochlear implant departments became of age and in hospital systems, rather than thinking of it as a comprehensive hearing healthcare continuum, I question that. I do think that we can learn a lot from the early learning world. I specialize in pediatrics, so I have looked a lot at early learning. We have more in common with early learning than we do with childhood deafness right now. In terms of, if you look at the strategy that was utilized and is being utilized very effectively with early learning to put the spotlight on the importance of investing earlier in children's lives with quality education, with quality experiences, what they've done is relied on science, and they've translated that science into understandable terms. And that's why we have the Harvard Center for the Developing Child. It's very much translated science into user-friendly messaging that parents can understand, professionals can understand. And what they've done is they have the private sector. There's been 5 private family foundations that came together and said, let's make this a priority. And they recruited business leaders across the country that could join in the advocacy efforts, that this became a no-brainer of how we need to be investing in young children. So I often wonder about I think this is a no-brainer in terms of a quality investment, and in terms of how it dramatically changes a person's life, dramatically and changes their ability to become a taxpayer, to contribute back to society. And so I wonder if we have used that strategy of leveraging business leaders, people who are in the distribution business, people who are in the, in terms of CEOs of large entities. If we have made that appeal with them in terms of that they're joining our militia and joining to make the case, because I think it is a no-brainer in terms of investing in cochlear implantation.
Thank you for that perspective. Jason, you're up.
Well, thank you. I do think overwhelmingly the lack of consideration of hearing healthcare as important in the public health landscape is huge. Outside of this bubble, right, it's got a long way to go. I think the fact that many You know, many physicians, providers, audiologists, so forth, don't keep or don't look to improve that awareness. Okay, again, we're all here, we're all on the same page with regards to this conference and ACIA and many of the, you know, of course, all the professional associations that we're members of, but that by far, number one. The education piece also, I think, is as Teresa said, we get in our own way, but I know that many audiology programs still rely heavily on manufacturer authored content and presentations rather than focusing on understanding the auditory system, the psychoacoustics, the physiology, the neurocognitive factors and influences. The need for increased education and understanding continues in the clinical setting. In general, not many providers are confident in discussing CIs with patients or making the appropriate referral. An ENT group I was with, it was very common for, and we did not actively implant, I programmed, but again, that was a provision that I brought as I joined that practice. Many practitioners, ENTs, even GPs, never even mention cochlear implants to their patients or present it as an option. Many would recommend continuing hearing aid use because the hearing's not bad enough. Again, we're getting back to that standard of care, best practices. And I say best practice as far as a having a universal set of maybe, you know, guidelines and so forth when discussing their hearing healthcare. Unfortunately, financial considerations and profitability influence this in GPs and ENT practices. You know, when there is an audiology clinic or there are hearing aid sales and the profitability there, they don't want to lose that patient maybe. Oh, they've been doing okay so far. So yeah, I do think we get in our own way. We understand this, we talk about this, but outside of these four walls, if you will, there's a great deal of opportunity to improve. You know, not for this discussion, but the OTC, the over-the-counter provisions, I am actually supportive of. I believe that's going to help, you know, in that public health awareness. So reimbursement, Dr. Majirian, of course, spoke to that. That would be the other, he is definitely the expert in that way. So yeah, these are huge impediments to progress and access, not access, but acceptance and utilization of cochlear implants.
Howard, if I could add one more comment, if you don't mind.
Yes.
I think that have we built in the places where there's developmental screening for children? Have we built in asking, did your baby pass newborn hearing screening? Did you follow up? In screening questionnaires for adults, is it built in about checking and asking about the hearing and hearing difficult situations? So I think that that's part of it too, is are we putting our messages in embedding it into existing practices? And I had a conversation last week about pediatricians and why pediatricians so much of the time tell a parent, let's wait, and let's see until they're older. And the reason why they do that, as they've researched it out, is that they don't know what to say because it's a difficult conversation. It's a hard conversation. But if a child had cancer, they know exactly what to say and what to do. So are we building in places, in counseling tools, in different places so that it's accessible, so people know what to say and do and when to say and do it?
I would want to mention one more thing quickly. I think with regards to reimbursement and the costs and funding and so forth, that the cost associated with not addressing the hearing loss, with not moving forward with the intervention, right? The social costs, the additional medical costs, be it, of course, the concomitants with hearing loss and depression and falls and all these sorts of things. Well, what kind of additional burden that puts on the medical system, and of course, your social and vocational burdens as well. So the cost to not intervene definitely needs to be considered, and I think may be something that should be looked at when looking to up those reimbursements and stuff with insurers.
So are we victims of our own success in that we have built a tower that is beautiful and has been very successful, but now is maybe isolating us from mainstream audiology, mainstream medicine, and the broader public, so that cochlear implants become sort of this special thing that you get when you really absolutely have to, and never before that. It's not really perceived as part of the continuum, the true continuum of care. And so just any comments regarding that from anybody and how we could address that. Jason, you have any thoughts on that? Or Peter, you were going to say something.
Yeah, I was just going to say, I do perceive that there's some of that there, that's a real concept. And that goes back to a few things that were mentioned throughout the course of this presentation, that of the importance of awareness, making sure that people really understand their options and are having truly informed consent when they're making decisions about their hearing health. And that's obviously always a challenge. I think the advocacy that you mentioned earlier in an earlier thread of comment is just so very important. ACI Alliance is all about research and advocacy, and the real question is how do you mix the science with the public policy? And I guess what I'd say to that is you rely on the science. Obviously, science is what drives practice, but there's a lot of competing priorities on Capitol Hill within existing payment programs. Whether it's Medicare and Medicaid and the VA, federal programs, or private insurance plans. The fact is, if people don't understand and don't know about the benefits of CI and the smile on people's faces when they first hear through a CI device, that's a very compelling message. That's a compelling notion that can really address and break down maybe that barrier that you've just identified, Dr. Francis. It's important that in the competition of ideas, there are people from this field, including obviously all stakeholders, but including patients for sure, who are making this case, who are educating people who don't know enough about this and pushing this as a priority. Who's to say that funding CI healthcare is more important or less important than fixing lead pipes or funding fighter jets or doing any one of thousands and thousands of things that the federal government is called upon to do and fund on a daily basis. So we have to be there educating people about the importance of this and jockeying for position, frankly, trying to elevate and prioritize CI access, so that you can have good patient outcomes in the end.
Thank you. Wonderful questions, and I wish we had a full hour, another hour. I will, though, read the last one that I see here. So, do you have suggestions as to an in with pediatricians to increase their awareness, not only of hearing loss, but also auditory technology? And you could say the in would be with the primary care physicians around older patients, etc. Quick thoughts around that, Teresa, Deb, Cliff, Jason.
That's a $64 question, isn't it? Yeah, I think we have to look at what are the developmental screeners that are being used by family practitioners or by pediatricians, and is that being embedded in it? So I think it's working with the authors of that, the colleagues of that, and that's on a national scale that I think we have opportunity. I also think we have to get, right now we have cochlear implants set up as a failure-based system. And what I mean by that, you failed at having hearing aids, and now you have to go to the implant center. And that's a negative connotation that we need to change that attitude about being a positive.
Thank you. We have one more minute. I'm going to actually just take this opportunity to thank the panelists for your incredibly thoughtful, insightful comments, the time you spent preparing and your engagement in the last hour. Clearly, as a field of study and practice, we need to further develop the concepts discussed this morning at the organizational level, including all our stakeholders. But we also need to include those that are outside of our organization. They are certainly critical partners in realizing the future that we should plan and work for. I am curious to see what comes of our discussion, whether or not we can actually have this discussion continue and actually result in some actions that will prepare us for the future, because the future is coming. Any last comments from anyone? Thank you all for participating.
Thank you so much.